Lori, thank you again for doing this. Um, for those tuning in, I'm with Lori Thompson Marat. Did I say that correct?
You did.
Awesome. And Lori is a longtime friend. I stopped counting the years already. We've known each other for a long time. And you're now a hospice nurse, and you've been a hospice nurse for quite some time. How long, as a matter of fact, have you been?
It's been 20 years, so it's my goal to enlighten and educate as many people as possible about the benefits of the services that we provide.
When people hear hospice, it's so closely associated. They automatically, it's almost taboo. How do you bridge that?
You know, you're right. I mean, people think if they sign on to hospice, it means they're going to die right away. And that's not true. I mean, I think over the years we have evolved somewhat, but when I first started hospice, doctors would wait until patients were actively dying before they would refer patients to hospice. So the mindset became that you sign on to hospice, you're dying. And so I think that over the years in educating the physicians and social workers and people that work with patients that are terminally ill, they're making the referrals earlier so that patients can establish rapport and communication with the providers that are caring for them. But there's services out there, and it's a hospice service that can provide some help at home. And I try to flip that negative into the benefit of the service. There's no downside to hospice. It's a benefit that they're entitled to. Their insurance covers it. And if they don't like it, they can sign off of it. And typically then, you know, we have success in getting people to understand that they can get some help at home. And it doesn't mean that they're dying tomorrow.
Is it true that they lose their access to their doctor?
No, that is not true. And that is, you know, a myth that people do have about it. They are entitled to choose one attending physician. And in addition, hospice also provides a physician because our doctors are available 24/7 when often a private physician will not be available on weekends or after hours. And they can also see consultants if the consultant is not related to the terminal illness. So it gets a little confusing for people, but yes, if they have a primary doctor that they want to continue to see, and that doctor is agreeable to that doctor, can continue to see them.
What about calling 911 if there's an emergency? Is it true that you can't call 911 once you sign up with hospice?
You can call 911. I mean,
these are all myths. These are all things that I hear.
Well, and there's some truth to it in the sense that I have had patients tell me that other hospice companies have told them that they cannot call 911. The truth is, you can call 911, you can do whatever you want to. You just need to notify the hospice company that you're on your way to the hospital, or notify the hospital when you get there that you're a hospice patient. And then what we do is we will send one of our nurses over to the hospital, to the emergency room, to find out what's going on. So if someone fell out of bed and they broke their hip, we want them to get that fixed. But having hip surgery under hospice is not, it doesn't go together. So we would ask them to disenroll from the hospice program, get their hip fixed, and then they can come back to hospice when they're ready. On the other hand, if they go to the hospital and it's something that's hospice related and we can treat it, we have the option of either admitting them directly into the hospital under a contracted bed, or we can take them back home and maybe put them on crisis care. So yes, they can call 911. We just ask that they also notify the hospital.
And what determines the level of care that they're going to receive from the very beginning that you meet this person? What are the parameters that you look for?
So at home we have two levels of care. We have routine home care, and then we have something called crisis care, continuous care. Routine home care is when the team members come and make visits and they leave. A nurse will come, check everything medically, and make a plan with the patient how often they're going to come. And the frequency of those visits could be daily, could be once a week, depending on the patient, and that can change at any time. If the patient goes into some sort of a medical crisis, let's say they're short of breath, their pain is out of control, something that they would normally maybe go to the hospital for, then we can escalate that routine home care to the crisis or continuous care level of care, where we actually have nurses around the clock with the patient in the home, in contact with the physician and getting the proper medications and treatments to get that symptom under control. So it's our job and it's our expertise to manage symptoms at end of life. Okay. And frequently, if I have a patient that's in the hospital and they want to go home with hospice, I may send them home with 24-hour care for the first 24 hours just to see how they manage at home. They may have new medications, they may have new treatments. We want to make sure that the family is educated on how to properly give those medications and treatments. Sometimes the ambulance ride home is a little bit rough, and they may decompensate on that ambulance ride. So frequently, we may start with 24-hour care for at least 24 hours and then reevaluate. And we do reevaluate that every 24 hours in the hopes that we get that symptom under control and can put that patient on a routine level of care where people are just coming and going and their symptoms are stable.
Do you see more people planning their futures, or do you see people just not prepared? We being in home care, not everyone has insurance, not everyone has long-term care insurance. People are not forward thinking like that, and I think it comes back to the stigma of we want to live forever. We don't want to think about that. Are you seeing people making preparations?
I'd love to say yes.
Yeah.
I would say over the 20 years, I can see it more. And I think part of that is because physicians are becoming more educated. Physicians can do something during their visits called advanced care planning. And they can talk to their patients and bill for advanced care planning and try to get an idea of what their patients' wishes are. But I think there's a big stigma about having the conversation about what your wishes are. It's not that often that I come across people that have living wills and have talked with their family about what they want. And that's really difficult when the patient is too ill to tell us what they want, and the family is having to make that decision without having had that conversation.
You as a hospice nurse, what would you say was the number one regret that you have heard from folks?
I think that family is probably the number one that I hear. Not so much, that they've worked too much, but that they've lost contact with family. Or actually, sometimes it's more that the family has lost contact with them.
How has the pandemic affected that, and how are you doing things differently as a hospice nurse?
So I have seen a tremendous number of people who have been so isolated and have cognitively declined because they don't have the social interaction that they had prior to the pandemic. Zoom has been helpful. FaceTime has been helpful. And then, sometimes just even the nurses seeing them is contact, is human contact that they are not getting from their families because they can't.
There's been a lot of learning, that's for sure. Mm-hmm. And a lot of adapting. To go back to to regrets. I know my sister and I, being in home care for so long, have had that conversation with my mom. But again, that comes from spending time with your family. The more time you spend, the more you learn, the more you know, and the more you can share. Is there anything, Lori, that you can think of that you would want people to know about hospice, even on how hospice works with home care? Because we don't do what you do, and you don't do what what we do. So we complement, one another.
Right. Well, I think, that has come up in conversation where people think that not only do they think they're going to lose their doctor that we already talked about, but they think that they may lose the care that they already have in the home, or that it will interfere with. So whether it's, private duty that you're providing, or, Medicaid patients that have homemakers or companions through a Medicaid waiver program, the hospice does not interfere with any of that. And like you said, it really complements each other, because we can utilize your staff to give us the heads up on what's been going on when we're not there. So if you've got a caregiver in the home, they can sometimes give us a better report of what's been going on than the patient or family may be able to give us.
Well, I mean, all of us working together keep folks out of the hospital, and that's what the goal is.
And that is what the goal is.
Thank you, Lori.
So thanks a lot. I appreciate